And as you can see that today we have a guest speaker. This is Dr. Matteo Vata, and we have been friends for many years, and he was a faculty member in our department and actually run our clinical sequencing laboratory in the medical genetics department. And now he is working in a company called Invita Corporation, and that is actually one of the largest clinical genetic sequencing company in the world. And they have been doing a lot of different level of sequencing, but different from us. Their focus is most on the clinical applications. So we have, throughout this course, we have talked about the technology, the analysis method, and we want to go fancy, we want to go fast, but in many cases, we didn't talk about how we want to go accurate, and then the reproducibility part. So that is super important for the clinical applications. So we will have Dr. Vata here discuss the regulatory issues and the ethic issues related to the clinical sequencing. Before we get into that, I want to have a little announcement for the final projects. Okay, we do have the course project as well. So first of all, we have now 29 students across both School of Informatics and the School of Medicine. So we will have group projects, and this will be 6 groups, and each group will have 5 people. The one group will have 4 people. So what I'm going to let you guys to do is after the class, you do it, form your own groups. Okay. By the end of by the middle of next week, please send Jill email and telling us which group you are in. And if you have trouble to identify group, we still have some time to fit people into some of the groups that are not be putting together. So I will send out the logistics in the future in terms of how to judge the projects. But in general, the projects can have 2 different types. One is you pick a data from the public domain, and then you do the analysis, you write a report like a mini paper, and then we do the presentation. The second type will be more of the review. For example, in the past, we have some of students review the assembly algorithm. So there are maybe 5, 6 assembly algorithms, and he downloaded some data. He has actually compared multiple algorithms and gave that type of review report. And so your final project will be judged by 2 components. One is the presentation, and the other one is the final product, which is your report. The presentation accounts for 10% of your overall score in the course. Okay, and that 10 point will be divided into 2. One is 5 points, that is a scientific level you have achieved. And so your whole group will share the exactly same score. And then the second 5 points will be associated to your individual person. And then in terms of the level of engagement of your presentation, as well as the way you answer questions. So I'm expecting that the presentation will be group presentation as well. So not only one person coming here, otherwise everybody else will get 0 on that part. Okay, so that is the projects part, the presentation part, and then we'll come to the written report. And I forgot which day it's still, but it's written on the syllabus. That will count for 20 points. Okay, and then your whole group is going to share that with a little bit flexibility. That by the end of the project, you need to tell me the contribution of each individual person. Okay, so I will only look at receive 1 report from each individual group, and I will send out the specific format of our report. So basically, that is a 4-page report, and reference is not included. And we'll get to that point later in the lecture. Again, the more emergent thing is by middle of next week, and send Jill the group assignment so that we can getting things prepared. Any questions so far? Okay, so now we will get into the lecture, and this is not too much math, I think.
No.
It's more on the regulation components. Thank you very
much. Thank you. Thank you, Dr. Liu, to have me here and presenting what Dr. Liu has said already, the regulatory part of clinical sequencing. I will go through the clinical laboratory accreditation system, the clinical laboratory phases. So what are the phases that the clinical lab is divided in, the clinical laboratory requirements, and the testing phase, and what it means also in terms of reporting for the physicians and the patients. So the first part is the accreditation. So what differentiates a clinical laboratory from a research laboratory is that the clinical laboratory must obey to the guidelines, standards, and procedures based on two of the major bodies that control and guides the vast majority of the clinical laboratories, not only in the United States, but also worldwide. The first one is the College of American Pathologists, which was established in 1946, and the second is the Clinical Laboratory Amendment, Improvement Amendment, which was established in 1988. Currently, the CLIA covers over 260,000 laboratories, clinical laboratories. And the main objective of both of them, both CLIA and CAP, is to define the quality standards of clinical testing in order to ensure accuracy, reliability, and timeline of the testing completion, in order that wherever the test is performed, hopefully it will lead to the same results, to the same level of quality, and therefore, whoever is doing the testing, whatever laboratory is doing the testing, should hopefully obtain exactly the same result.
So you said this is not only for the United States?
No, the CAP, College of American Pathologists, offers the accreditation also for laboratories that are outside of the United States.
How about CLIA?
CLIA as well. You can
But other countries can have their own body to.
Absolutely, there is a European body, for instance, with an ISO 9600, and so there are other standards. But you can, as a laboratory, someone can apply for accreditation of CAP and CLIA. The CAP has even some stricter requirements, and therefore, who is accredited by CAP and has also the CLIA accreditation, usually it is required to have a biannual inspection by CAP, not necessarily by CLIA. So CAP will let's say, will be used as the main accreditation system, if you will. Meaning that if you have both, you need to pass the accreditation for CAP, and then this will automatically be good also for CLIA. So there are a lot of parameters that clinical laboratories need to take in account. The analytical validity, which is how well the test predicts or detects the presence or absence of a genetic change in a particular genetic change in a sample. The clinical validity, so how well the genetic variant being analyzed is related to the presence, absence, or risk of a specific disease. And the clinical utility. Can the test provide changes in management, in diagnosis, in treatment, prevention of the disease that will be helpful to the patients? As I said, the CLIA and CAPs, they have some oversight to the clinical laboratory, and there are several items in which they have really very well-structured guidelines. One is, the oversight over the process. So establishing a process for offering the testing. So the laboratory needs to write down what we call standard operating procedures to offer a test, why they offer the test, and then not only defining the type of test, if the test has multiple technologies to be used, they need to have clear instruction for ordering and submitting the test. So needs to be also said if and when a test is required, or when a test is recommended, or when a test is not recommended. For instance, a test for Huntington disease will not be recommended for anyone that is below 18 years of age. That's a guideline that it's part of the American College of Medical Genetics and Genomics, and has been, of course, embraced by those accreditation bodies. Also, process for interpreting and reporting the results. So the laboratories needs to use a standard way to interpret the variants, and also to ensuring that all personnel that is touching, either physically or bioinformatically or informatically, meaning computer-wise, the sample, they need to have a proper train, and they must have also proper accreditation. The other oversight that the CLIA CAP has on the laboratory is the analytical validity. So does the test detect what it's supposed to be detecting? So they have oversight as how many false positives, false negatives, what is the threshold that is acceptable for the laboratory, and so forth. Also, clinical validity. So they need to see that the clinical laboratory is following medical guidelines, so the latest medical guidelines. They need to know, what is, let's say, how the clinical testing is established and performed, which can depend on many evidence, scientific evidence, and frequency of the disease, type of modality of inheritance, and characteristics of the disease itself. And then, of course, again, training and qualification. So when a clinical laboratory is established and they want to start really setting up a clinical test, they need to really have a checklist like clinical utility. Is this test necessary? Is this test useful? So for a certain disease, conditions like prevalence, so there could be a disease that is very frequent in a particular population where the clinical laboratory is established, but may not be, as frequent somewhere else. Like there is a neurological condition called Charlevoix-Seguinet, which is very common, relatively common in the Quebec region of Canada, but otherwise it's very, very rare due to founder effect of French settlers that came to Quebec. Or cystic fibrosis, which is extremely common in the Caucasian population, but is not so common in, for instance, Asian population. So prevalence of the disease, the ability of providing a molecular diagnosis, change in treatment, management, or prevention of the disease itself, or just the ability to provide planning, family planning tools, and or to provide just general knowledge. For instance, progeria, which is an early aging disease, it's very uncommon. If I remember off the top of my head, I think that the prevalence is 1 in 5 million. So obviously, it will not have a huge impact on the overall health of the population, but it will increase knowledge. So after knowing why someone wants to set up a test, a clinical test, they need to undergo the test validation, which will have to prove that there is a clinical and analytical validity for that. And we will go through those. Then the other let's say parameter is that this test, what test type are we going to use? So sometimes, for instance, for cystic fibrosis, there is a panel of known variants which are causing the vast majority of all cases. So probably, sequencing may not be as cost effective. It will be still effective to capture those variants, but not cost effective. So there are, SNP, CHIP, or other modalities that can be more cost effective than just sequencing. In other cases, for instance, Fragile X or Huntington disease, you need to have an expansion, the technology that is able to detect an expansion. And currently, with the short reads, unfortunately, next generation sequencing, for instance, is not able to do it effectively. So the test type is very important. Turnaround time. Turnaround time is when is the time between the sample is received in-house in the laboratory and the time that is signed out, the report is signed out by the lab director. So these can have very severe implications. So depending on the applications, so a metabolic disorder that is very, very severe, or a prenatal diagnosis which can have consequences on the decision of the mother and the family. Yes?
So is this checklist already established by the CLIA and CAP, or does it vary from different disease to disease?
Well, those are the test validation, and the test type is the laboratory is choosing the best technology, but every technology that is used clinically, it has some guidelines by the CAP. So that they have, threshold, quality measures, everything. We will go through all of them. So, and after saying, okay, this has to be done by 3 weeks, fine, or 1 week, surgical panel for, breast cancer, for instance, 1 week, then everything has to be put under a standard operating procedure. So everything has to be written. Remember, in clinical laboratories, whatever is not documented never existed. Another very key portion of the clinical laboratories is the personnel accreditation and training. So lab directors must be board certified by the American Board of Medical Genetics and Genomics for sequencing, of course, in molecular. Now things are changing. They have a unified fellowship called Laboratory Genetics and Genomics, but it's beyond the scope of this presentation. Genetic counselors that can be employed by laboratories, clinical laboratories, must be board certified by the American Board of Genetic Counselor. The technologist must also have a certification like a certified medical technician or clinical laboratory scientist, or they must have the American Society for Clinical Pathology accreditation and board certification. Bioinformaticians must have PhDs and scientists or genetic counselors that are involved in variant interpretation. They must have, of course, the Master for Genetic Counselors and the PhD and the in addition to the PhD, depending on their level of involvement, they must have also a certification from the ASCP, especially in some areas. Oh, sorry.
So what is the minimum requirement? Are all these people need to be independent people, at least 5 person, or some of the positions can be combined for clinical laboratory? Like a lab director and genetic counselor, can genetic counselor also serve as a lab director?
No.
So you have to have at least 5 people in any of the clinical laboratory.
Yes. So the lab director will serve as a technical director as well.
Okay.
Sometimes an MD can be a lab director, and the PhD board certified will be a technical director. Otherwise, both can be the same person. But otherwise, the genetic counselor cannot be a lab director.
Who is signing the final report? It's the lab director is signing the final report.
Lab director are signing the final report, and they have the full liability of the report.
The genetic counselor is more interacting with the patient. Is that how it works, or
there are several let's say tasks that genetic counselors in the clinical laboratories are doing. One is client services, so interacting with the healthcare providers or patients. Also, they can do variant interpretation if they have been doing that before, and they can do the clinical summary of the report, so the report writing part.
I see. Okay.
Yeah. So there are 3 major phases in clinical lab. One is the pre-analytical, where everything that belongs to the specimen, so specimen collection, transport, processing. So everything that is that is done before the actual testing is called pre-analytical. And so everything has to be defined very well. So how to handle a specific sample, how to be transported, how to be processed, everything has to follow the SOPs. The analytical is the actual testing. So when the sample really is processed in the laboratory, for the actual test. And the post-analytical will be all the bioinformatics, the results recording, the interpretation, and the reporting. Pre-analytical. So sample tracking is very important. So the clinical laboratory must use specific collection kit. They can choose, but they need to put in their SOPs which collection kit, and the fact that they have proven that those collection kits are effective. They allow a specific tracking, detailed knowledge about how well the sample is when it arrives at the laboratory and so forth. So there will be a lot of paperwork. So the requisition form that must be in place. There are some forms of ID, including barcoding, that must be present on the requisition form, matching the tube or the saliva kit or whatever other sample specimen collection has been utilized. And also everything has to be tracked. So if there is a courier, then the tracking system must be having double checking ability. A sessioning system, which is entering all the data that are concerning the sample, everything that is on the requisition form, and everything that has to match with the actual tube. So only certified technicians and technologists can handle and can do a sessioning. They have to use both barcoding and documentation and SOPs. In case that there are, sometimes there are technicians that are not accredited, but they are under the supervision or accredited and certified person. So whenever the accessioning has to be ruled by certified people. Then forms of identification for the samples. So there are a lot of laboratories that are using redundant way to undergo identification. So because of course, even though next generation sequencing is mostly used, and so you have your barcoding and everything else, but sometimes you have also 3 or 4 exome sequencing, or you have a lot of family members, and you want to make sure that the family members are actually family members, and that the DNA that you are testing is really belonging to that person. So the second phase is the testing, so the analytical phase. So every laboratory, whenever they want to set up a test, they need to undergo a validation study. Validation study means checking gazillions of samples in order to prove that they catch whatever they need to catch, and that they don't see whatever is not there. They have to prove accuracy, precision, reproducibility. They have to set up their reportable range, their reference range. They have to provide also the analytical sensitivity in some, quantitative analysis, also the lower limit of detection. For instance, if you have, I don't know, virus titering in the blood, then also they need to provide analytical specificity and the clinical performance characteristics. So validation studies are done using an adequate number of very well established or very well characterized samples in order to show that the test, the way that the experiment, if you will, the way it was designed, is able to capture everything that is supposed to capture. And whenever there is no variation in a specific portion of the target, then no variation is identified. So practically lower the false positive, the false positive, and all, of course, having hopefully 0 false negative. So there are samples that in next generation sequencing you have been probably using a lot. That is, that has been, I think, sequenced by Illumina, I don't know how many times, but and of
every other technology.
Yeah. So in addition to the sample type in the sense of how many targets each sample may have that could be useful for the validation, also the sample type in terms of if it is blood, if it is tissue, if it is saliva, if it is formalin fixed paraffin embedded tissue, and so forth. So one of the most important parameters that the validation study needs to prove is the accuracy, which is the closeness of agreement between the test results and the accepted reference value. What it means, if I see that the reference value of a particular sample was in-frame deletion delta 508 in CFTR gene for CF, then I need to prove that I have captured that variant all the time, using my system. So the scope of the assessment is to prove what the characteristic have been taken in consideration, because there are, for instance, some promoter variants, and promoters could be GC-rich, they could have homopolymers, or you can have a lot of repeated regions, so homologous genes, pseudogenes, paralogous, and so forth, gene duplications, and so forth. Then also what kind of calls you are supposed to capture. Could be just single nucleotide variants, small indels, or you need to capture also microdeletions that are, subchromosomal in nature and so forth. And also what the yeah. So the homopolymers are like stretches of A's or stretches of T's that sometimes are presenting. Yeah. Then also what the test is measuring. If it is measuring, for instance, diploid variation or somatic mutations or heteroplasmy, if it is a mitochondrial DNA analysis. So another parameter is the precision and reproducibility. So the laboratory must record the evidence that the test that that is run can get the same results whenever there are some minor changes, like if there is a different technologies that is running, it's a different day, it's a different instrument, it's a different reagents lot. So those should be let's say variables that should not impact, must not impact the results of a clinical test. So sometimes, and we have done all research, sometimes, we felt that was not a good day for our experiment. Unfortunately, there is no luxury of thinking about that in a clinical laboratory. So the laboratory must provide all the ratios of concordant results and confident results whenever there was a different technologies that was doing the same test with the same machines, or using the same technologies with different machines, and so all those combinations must be recorded and put in the validation package. Another parameter is the reportable range. So what is the laboratory guaranteeing that they can report? What is the target size that they can report? So in sequencing, usually it's the exonic sequence plus minus the 10 nucleotides inside the introns. However, there are some variants. CFTR is one case, BRCA1, that is an Ashkenazi Jewish variant that is deep intronic, and so forth. So there could be other off-target variants that needs to be captured as well in order to have a complete test. So exons plus minus 10 nucleotides must be guaranteed. Deep intronic promoter or branch site whenever they are proved to be clinically important. Also, they have to provide documentation showing what genotypes can be detected. Of course, the homozygous wild type, the heterozygous variant, and the homozygous mutant, but also sometimes mosaic, and so forth. Heteroplasmy. The other is the reference range. So essentially, the reference range is the upper and lower limit of a measurement. For instance, if you have a control population which is Caucasian, you are expected to identify the Delta 508 variant, roughly at 1.2% in your population. If you see that this detection diverges dramatically from what you're supposed to be identifying, something is definitely wrong. So one example that I put here, is like when you do blood tests for cholesterol, you have upper limit and lower limit of what is usually you are supposed to identify in a population. So the test, of course, needs to have accuracy, and the analytical parameters are shown here. I'm not going to go through. You can, it's the analytical sensitivity, essentially the probability that the test is positive, given that the person has the disease and has the variant, and analytical specificity, which identifies the wild type whenever the person, the subject, does not have the disease and does not have the variant. So essentially covers the false positive and false negative type of detection. The clinical performance characteristics, contrary to the analytical parameters, the clinical sensitivity and specificity actually is more leading to detecting the prevalence of the disease within the population, so the positive predictive value. So I put an example here, for instance, for long QT syndrome. Long QT syndrome is 1 in 1,000, 1 in 1,500 is the prevalence. But if you have very well diagnosed subjects with long QT syndrome using accepted clinical criteria, then you are expected to identify a variant that explains the phenotype in 65 to 75% of patients. Therefore, you should expect that your test is giving a positive results in that particular number of patients. Then you have a negative predictive value, which is the probability the subject with a negative screening test truly are negative and they don't have the disease.
So that would be not too much on the sequencing accuracy side. It is the interpretability of it.
Well, it's post-interpretation, if you will, is the clinical sensitivity versus analytical sensitivity. So it doesn't concern the sequencing per se.
Right.
It concerns the post-analytical phase.
Yeah.
Yes.
And normally, what are the range that is more acceptable?
Well, every disease is different. For instance, if you have there is a disease of inherited dwarfness, achondroplasia. Achondroplasia, 99.99% of cases will be defined by two variants, one in 99% and the other one almost another percent. So if you test for achondroplasia and a subject has a firm and definitive diagnosis of achondroplasia, you will catch that almost 100%. If you have a thoracic aortic aneurysm, which is isolated without any syndromic features, then probably you are going to expect to have a positive results in 20% of cases.
So those are all acceptable range.
Absolutely. So that's why the clinical sensitivity and specificity is very different from the analytical one. The other one is turnaround time, as I said. So the laboratory must monitor the turnaround time that they have fixed for every test. And every turnaround time must be appropriate for the type of test. For instance, expecting 2 days turnaround time for whole genome sequencing, is not practical. But expecting for a small gene panels for surgical purposes, that is done for surgical purposes for breast cancer. I think that having 5 days turnaround time or a week turnaround time is absolutely expected and necessary. So the appropriate turnaround time may vary by test type and the clinical application. There are certain clinical situations in which, of course, there is a need of a short turnaround time or STAT. And for instance, prenatal diagnosis is one case where they need to establish a short turnaround time. All the clinical laboratory must provide written procedure defining the turnaround time for each test, the reasons and the mechanism for monitoring the turnaround time, because they need to prove that apart from a certain deviation, there is a threshold that the CAP and the CLIA put as a deviation from the turnaround time, meaning that it can happen that a couple of tests may take longer than expected because of many reasons. Could be held off by the insurance company, or could be that the sample is not working, has failed, and so forth. But that has to be recorded, monitored, and they have to prove that they are not going beyond the threshold that is accepted for turnaround time. Clinical equipment. So every equipment must be recorded, given the list, location, identification. The laboratory needs to provide the calibration procedures, all the materials that are used for calibration. So keeping a calibration log, doing calibration verification, quality control, quality assurance. And they have to establish the acceptable limits. For instance, for a refrigerator, a refrigerator must be at 4 degrees Celsius, and the deviation that is accepted by that laboratory must not be more than 2 degrees one way or the other. They can establish more, but then it can be questioned by the CLIA and CAP. So the other thing is that the clinical lab needs to maintain a service log. So every time that a machine has to undergo service because it's broken, something doesn't work, or must be recorded, and the reasons why, what happened, and then what has been done in order to recover the utilization of the machine. So also maintenance frequency has to be established. Usually it's the recommended by the manufacturer, but cannot be, has to be at least every 6 months. And then, of course, the recalibration.
So, in order to ensure the turnaround time, and all the clinical laboratories need to have a pair of machines in case one breaks down, and how to deal with that situation?
It's not that you have to, but if you don't, if you don't achieve the acceptable threshold for turnaround time, CAP may, require you to have, some actions that you have to take in order to prevent them. And if you cannot do it, they can shut you down.
And all those logs needs to be paper-based, or it can be electronic-based?
Can be also electronic-based, but whenever requested, they can be printable. Yeah. So also the reagents, they have to undergo, all the procedures, written procedures, in order to provide the integrity. So to prove the integrity, or how to maintain the integrity of the reagents. So if they have to be in -20, so this -20 freezer must not have, a fluctuation in temperature. So the type of storage and where they are stored, so that everything has to avoid, in order to avoid cross-contaminations. And also they have to undergo a specific labeling. So the laboratory should ensure the accuracy of all the new lot of reagents, and they have to test with the current lot of reagents that they're using in order before shifting to the new lot of reagents. So in the wet lab, this is true for NGS, but in general, for every sample, a laboratory needs to put in place the standards and the range where they say what sample is acceptable, when it is acceptable, so what type, if they are accepting blood, they are accepting saliva, they are accepting blood dots, or they are accepting FFP blocks, whatever. So what type of sample is acceptable, and also the minimal requirement in terms of quantity and quality. Sometimes even though the quantity is very high, there could be, for instance, the 260-280 ratio that is very bad and may not be sufficient to undergo the testing. So for the reagents, the laboratory must put in place methods and reagents used for isolating the nucleic acid, to do the enrichment, to do the barcoding, indexing, and so forth, and also all the controls when appropriate and if applicable. For equipment, the sequencing platform, all the manufacturing versions of sequencing, all the software that are used in order to operate must be recorded in the standard operating procedures, including flow cells, including chips, including everything. The softwares have to be sometimes updated, and so the update process must prove that the new version of the software is working at least at the same level of the previous acceptable one before moving to the new one. So other procedures are in place for tracking the specimen during the entire wet lab. So there are some highly automated systems that are now in use in many laboratories, and so that we're using a specific barcoding or other codings. The specimen is tracked like a GPS. Essentially, they know exactly where it is, what it does, and how it performs. Then, obviously, when there are so much data, like in NGS, maintaining confidentiality of the data during transferring the data from the machines into a cloud system, if it is used, or into a server, must be maintained by obeying to all federal, state, and local laws, and by, of course, obeying the federal requirements that are the HIPAA. So everything has to be HIPAA compliant. Also, the laboratory is, the clinical lab is required to maintain all the data that is necessary to reanalyze the test for at least 2 years. So could be FASTQ, the BAM file, the VCF file, or all of the above.
Are the cloud allowed?
So before they were resistant to clouds, but if you have multiple passwords in place and the specific, let's say, safety measures, there are some limited use of cloud that can be allowed. If it is everything is encrypted, for instance, yes, can. So, yeah.
Between updates of softwares, if the developer, let's say, decides to change the format of the output, is that a criteria to not update?
So everything has to be analyzed, validated, and then approved by the lab director. So whatever was written before, which is essentially the step-by-step, how to do the test, needs to be, whenever there is an implementation, an update, or anything, any change, needs to be compared with the previous system, prove that is doing exactly the same job or even a better job. There is, sometimes you can have a better alignment or better clustering, everything. So if you have to prove that it is at least as good as the previous one, that does the job, so you have to do another validation, so a revalidation of the system, and then everything has to be documented and approved by the lab director and presented to CAP, because CAP or CLIA, they need to know that some changes have been put in place, what changes, what they're expecting, and usually If this is, this change occur in the year of the inspection, this will be one thing that the inspectors will look into. So the validation binders. So everything that so far you have been, I've been telling you so much of SOPs, standard operating procedures. Everything is then governed by a quality management program, which is, if you will, an umbrella SOPs, a big brother that needs to monitor, ensure the quality, of the tests done, the quality of the personnel and their training and everything else. So the quality management program must include all the metrics from the pre-analytical phase, how many errors are done in a sessioning, for instance, in the analytical phase, so during the wet lab, and then of course post-analytical phase. So they need to record any deviation and all corrective actions that have been taken. So if something was not working, what we have done in order to make it work again. And then, keeping SOPs for maintenance of laboratory records and upgrades. Same thing for bioinformatics. I will go very fast on here because all the, software and everything, but everything has to be, again, written down. I'm using A, B, C, D for D, E, F, G reasons, and I got these results which are acceptable, and everything has to be set up. And if I change something, if I update the software, once again, revalidate. Especially when the version is a major version change. If there is a minor version change, just can be compared, but is a mini validation, if you will. So everything has to, all the data flow has to be governed by the quality management program. Okay, post bioinformatics. So now you got the data. What do I do with that? So you need to keep in mind a lot of matrices like, quality metrics, depth of coverage, zygosity, where the variant has been identified, what type of variant it is, in what gene, and if this is a true finding or not. So far, orthogonal technologies have been used like Sanger or another form of next generation sequencing, or Paco Bioscience, or whatever, qPCR. There are metrics, especially in the clinical laboratory, with very large depth of coverage, very much used for statistical analysis whether a variant is a true call or not. And so sometimes confirmation may not be necessary, but that will have to be also defined by the laboratory what are the threshold and confirmed by the guidelines. So whenever we confirm that the variant that was identified in our patient is true, so it's is a true finding, we have to place this variant in five categories that have been given by the American College of Medical Genetics and Genomics as a standard for variant interpretation. So they can be either benign, completely benign, or likely benign, so where they don't have any bearing in the clinical presentation, or they can be pathogenic or likely pathogenic, where there is a level of confidence put here that this variant is indeed not only associated, but really causing the disease in this patient or the phenotype in this patient. But there are also variants that for which there are not enough evidence, and so they're called variants of unknown or uncertain significance. So the main question of a clinical laboratory is, could this variant be responsible for the disease? So let's, what's the crime? Is the disease. So how confident are we that this is really a genetic disease? There could be phenocopies. So how does it happen? So how common is this disease? And then the suspect, which is the variant, is that what kind of variant is this? What is known about this variant? So are there publications about how common is this variant compared to controls? Are other genes that could be responsible for the phenotype? And is this variant really the criminal or an accessory to the crime? Meaning, is it a modifier or an increased risk allele rather than a clearly pathogenic variant? Obviously, we have to collect evidence. And collecting evidence, luckily, nowadays, it's easier than what it was before because there are a lot of databases. So one of the most common that you're using practically all the time, I guess, is the NOMAD database for controls. So what do we know about those controls? Are all those controls really healthy? We don't know. But we don't have a better way to use other control databases otherwise. So every time that we identify the variant, we have to undergo the clinical interpretation of the variant. So what is the association between the change that we see in the DNA and the clinical phenotype that the subject is presenting? So we have to analyze the variant type when we can to do family studies or population genetics, or if we are lucky and we have the association with a research laboratory to do functional studies. So variant types, there are many types of variant that can be detected. The most dramatic form are so-called truncating variants, nonsense variants, frame shift or splicing variants. For splicing variants, obviously, they are affecting the invariant position in the intron, so the plus, minus 1 and 2. But there are some, of course, caveats. And the caveats are, as you know, not all truncating variants may undergo, may lead to the degradation of the product. So a nonsense variant or a frame shift variant, if it occurs in the second last exon before 55 nucleotides before the end, then it can be the end of the second last exon. It can skip the nonsense mediated decay. And there are some genes for which the truncating variant is not going to lead to nonsense mediated decay most of the time, even though they are going to be on the 5' end. There are also cases where a gene is coding for multiple isoforms. So there are multiple transcripts associated with this particular gene. And so we have to be mindful whenever we identify, for instance, a splicing variant. So what isoforms is affected? And if this isoform that is affected is biologically important and clinically actionable. So there are genes that, for instance, they may have spliced out variant, the exons. And if the exons are blunt, they are going to keep the frame intact, the reading frame intact, and they may lead to a less severe phenotype. For instance, in Duchenne, in the DMD gene, the dystrophin gene causing Duchenne muscular dystrophy, if we have a frame shift or a large deletion causing a downstream termination of the frame, reading frame, then we are going to have much more severe disease. When we have a deletion of in-frame deletion of exons, it may lead to a Becker muscular dystrophy, which is a little bit less severe. Usually, missense variants have been historically disregarded and filtered out whenever massive sequencing was performed. However, sorry, missense variant. I went too early. So no, missense variant, are another part of another type of variants that needs to be taken in consideration, because depending on the position where they are, and if they are affecting a very well conserved residue, they may be providing evidence toward pathogenicity, versus if the residue is not conserved, they may instead be providing evidence toward benign. There are a lot of in silico prediction system algorithms. I put one that seems to be trendy right now, the MCAP, which is essentially a combination of 9 algorithms that are listed here, from the SIFT polyphen, the CAT score, and so forth. But also there are Grantham score used for analyzing whether a variant could have an impact on the protein. The problem of all the prediction system is that they predict the impact on the protein that is affected, not necessarily if the effect occurs on binding partners of that protein. So also, even though I said before that sometimes frame shift are more severe than in-frame events, there are some in-frame events that can be extremely dramatic. One example is the delta KPQ in long QT syndrome. This is the depiction of a sodium channel. So those are 6 intra-membrane segments that are part of 4 transmembrane domains. And so this variant is very well characterized, has been very well characterized to be causative and pathogenic for long QT syndrome. However, there are also non-frame shift or in-frame indels that may be completely benign or tolerated. I prefer the word tolerated toward benign, because benign has an implication that I don't think really exists unless it's proven functionally. But in this case, for instance, this ZIG3 gene, which has been involved in heterotaxy, a form of heart defects, and a form of laterality defect. And so you can see that these, the protein that is generated by the ZIG3 has stretches of residues, same residues. And we know that depending on the species that we look at, there could be a tolerated lock or duplicated numbers of those residues. So we can have in-frame indels that can be tolerated. So synonymous, that's what I was talking before, that were usually filtered out. The synonymous changes, actually there could be some synonymous changes that are very important, like the last G of the exon, which has been implicated many times in regulating the splicing. The other thing that are important is that there are portion of the exons where there are binding sites for splicing elements. So those stretches of DNA are called exonic splicing enhancers if they help the splicing, or exonic splicing silencer if they prevents this splicing. So in addition to that, splicing prediction should be done also for synonymous changes. And if a clinical lab is able to do also the transcriptome can be done. and definitely family studies. So to do a family study, of course, we need always detailed clinical information, family history, biological parents. Sometimes we could not confirm the paternity of a case. And it's very important to have biological parents, because if the variant is present in a subject with otherwise negative family history and is presenting de novo, then this is an evidence toward pathogenicity. If there are variants of uncertain significance that are identified, for instance, an autosomal recessive case, knowing the phase, it's important if they are in trans or in cis in order to determine if they are potentially pathogenic. But in autosomal dominant cases, if we identify two VASs and they are in cis, also these can support against pathogenicity of one or the other. Very important whenever you have access to a family to do a family study. So to show that the variant is really co-segregated with the disease. So every affected member of the family should have the variant causing the disease, and the one that are not affected should not have it. However, there are very few Mendelian disorders with 100% penetrance. So in, for instance, cardiovascular diseases, most of those diseases, they do have incomplete penetrance. So there will be cases, especially in youngsters, where the variant may be present, but they may not have clinical phenotype. So age dependency, clinical variability of the disease has to be taken always in consideration. Population genetics is also very important. So knowing that the variant is present or is not present in the population and how frequent it is could have a very significant impact on the classification. So if a variant is absent or is extremely rare in ethnically matched controls, then this could be a moderate evidence for pathogenicity. So there are cases, of course, where due to incomplete penetrance, a causative variant may be still common. So there are common variants that can be identified as predictive of a certain phenotype, but they may not be sufficient in isolation. So sometimes if there are autosomal recessive disorder, then you need two variants, like in the case of CF, cystic fibrosis. So this variant, the Delta 508, which is a in-frame deletion, is actually present in NOMAD in 1.2% of the Caucasian population in heterozygosity. So if you use a filter of 0.1%, this will not show up in your result. So you have to know what to look for and how to filter. So usually, it's the conventional wisdom is that, okay, a variant cannot be more frequent than the disease. Okay. Then, if you're autosomal dominant disease, you need one variant. So one allele to be mutated. Autosomal recessive, you need two. End of story. Not so fast. There are some variants that are, again, more frequent than the disease. And there are some diseases that can present as a digenic or oligogenic disease itself, depending also on the severity of presentation. There have been studies for two cardiovascular diseases, long QT syndrome and hypertrophic cardiomyopathy, and this is the prevalence of each of them, in which a significant portion of a patient, they have been identified with more than one pathogenic variant or likely pathogenic variant, so clinically actionable variant. And usually they've seen in those studies that those patients, they had a more severe presentation or an earlier onset of the disease. So I put here two examples, one for long QT syndrome, the KCNE1 variant leading to asparagine change at position 76 is present in non-Finnish European in 0.011%. There is a myosin-binding protein C3 variant that is leading to a deletion of 25 nucleotides, which is present in 3.2% of South Asians. If you have one variant, you may have a subclinical presentation, meaning you may not feel anything. You are homozygous or compound het with another variant, you can have a severe disease. So is this autosomal recessive? Is it semi-dominant? Probably. Another study on dilated cardiomyopathy, another form of heart disease where the heart doesn't pump well, they have identified that a large portion of those cases, they have been identified with multiple variants. So there are common variants that could be an increased risk allele, or they could be low penetrant alleles, and so they may need to have, those patients, they may need to have a mutation load, a certain threshold where they need multiple variants in order to have the disease, an avert disease. There are, in addition to sequencing changes, of course, we have more complex rearrangements. So copy number variant, and next generation sequencing is definitely able to detect those. Using the depth of coverage, you can see if you have lack of coverage in one portion leading to homozygous deletion or heterozygous deletion when you have roughly half of the coverage, or if you have a gain of DNA material. Doing copy number variants by next generation sequencing actually turned out to be more concordant and more accurate, and leading sometimes to have a good detection of breakpoints, especially if you're using genome sequencing. So this is one example where split read analysis is utilized in order to identify a variation that leads to a partial deletion of this exon. And an accurate analysis of the split read led to the identification that in addition to a partial deletion occurring between exon 2, intron 2 and exon 3, there is also a inversion of all the other exons. And this was done by next generation sequencing. This inversion would have been missed by MLPA, would have been missed by array CGH, would have been missed by SNP array. So once we know the variant and we have given a clinical classification, we need to report the findings. So the clinical laboratory report goals are to communicate the critical information in a clear way. We need to give findings that hopefully definitely explain the symptoms. They may suggest additional testing or evaluation. For instance, get into another technology to confirm some of the findings, and also put the limitation of the testing, because every technology that is used has a limitation. The reports should reflect why the doctor ordered this test. So it was for differential diagnosis, was for other reasons. Were other tests done before? What they have found? So is it something that has been confirmed or not confirmed? Family history, of course, and how the genetic results fits into the context of the subject, and if they are explained in the phenotype, and if there are additional evaluations that can result in conclusive results. So the good news and the bad news of clinical laboratory doing genetic testing is that a genetic classification is not always carved in stone. So it can change according to new knowledge. So for instance, when we had very limited number of controls, some variants could not be detected, some variants could not be identified for their real frequency in the general population. And so they could have one classification. So classification can change towards more pathogenic or to less pathogenic, depending on the new knowledge So changes of classification is one of the issues for which the clinical laboratories require additional infrastructure. So we require to have more knowledge, access to databases, integration of, for instance, cytogenetics and molecular testing in order to get everything under one umbrella in order to have the same quality and standard for each test type. And also being able to do reanalysis of the variants in order to see if the conclusions are the same or they are different. To be able to collect the phenotype, because if we do not know the phenotype of the patient, we cannot make the correct association. And also to expand the phenotype. So counseling has been extremely important in clinical laboratories that do have genetic counselors on board. They can be utilized also to provide the correct expectation that a subject, a patient, must have toward the genetic testing. So what they should be expecting to identify what are the possible results, what a negative result or a positive result can mean for them, the understanding of the results on their management and or the family management. What are the benefits and also the risk, and what is the effect on the family? For the providers, genetic counseling can help of what tests they need to really order. So usually when you have a very well-established diagnosis, a genetic panel can take care of it, meaning you have a defined number of genes, you have a very high depth of coverage because of course the target is limited. So you have also the best ability to have complete coverage of all the nucleotides that you need to cover. Also the interpretation will be easier because you are interpreting variants in genes that have very well established association with diseases. And also they fit better the reimbursement model of the healthcare system. But if the clinical picture is not that obvious, then you can order, you can offer the exome sequencing. Exome sequencing covers 1 to 2% of the entire genome. Usually, the clinical grade exome has been established by ACMG to be not less than 70x depth of coverage of minimum average of coverage of 70x, but most commonly is used between 100 and 150 average of coverage clinically. It has been proven over and over that the positive detection rate it's between 20 and 25%. So what it means is that 20-25% of all samples sent to be done by exome sequencing will come back with a positive finding. Exome sequencing does not capture everything. So not all the targets are well captured, and so there are holes. And these can be used as a reflex test, test if the panels were negative. And they require always confirmation due to the lower depth of coverage. But if you are not happy with just going toward the exons, you can order a genome sequencing. So this provides a nearly totally homogeneous coverage, and the minimum coverage that is clinically acceptable is 40x. Of course, you can do an initial interpretation of some specific genes that could meet, the clinical, let's say, presentation of the patient. But otherwise, everything else that is in deep intronic is of difficult interpretation, cannot be interpreted. In both cases, exome and genome, there could be findings called secondary finding before we're called incidental findings that may not be what was the primary purpose of the test. So the American College of Medical Genetics and Genomics have put forth the recommendation for reporting those secondary findings. because some variants in other genes, those that were supposed to be, let's say, causing the disease of the patient, in the patient, they may bear variants that are clinically actionable and very important for the future management of the patient. So here is the list. You don't need to read here, but just going, through this list that of those genes that are covering hereditary cancer, cardiovascular diseases, usually cardiomyopathies or arrhythmias. Also, 7 genes in the spectrum of thoracic, aortic, and aneurysm, syndromes like Marfan syndrome, Loeys-Dietz. Also, 3 genes for familial hypercholesterolemia, malignant hyperthermia, Ehlers-Danlos syndrome, and neurofibromatosis. So those are all the genes that a clinical laboratory is required to, if they found a variant that is clinically actionable, likely pathogenic or pathogenic in one of those genes, they are required to disclose to the physician, which has to disclose to the patient. Well, I hope that I gave you a brief overview of all the requirements in clinical sequencing, and I can take any questions.
So the last piece is also called incidental finding, right?
Yes.
So you are saying it's required to disclose.
Yes.
But when you disclose it to the
Whenever they are in those genes.
right,
Yeah.
do you need to do other orthologous testing for this list?
If you have the ability to have confirmed
Yeah.
those variants in-house, yes. Otherwise, if a laboratory, there are some laboratories that are specifically utilizing one technology, they may recommend to have these patients tested in another clinical laboratory for confirmation.
For the incidental
Yeah.
findings. But for the clinical actionable ones that are related to this particular patient and this syndrome, you will have to do another confirmation.
Yeah, that's usually what is done. Yeah.
Okay.
But the thing is that normally both the primary finding and the secondary finding are also confirmed by the same laboratory.
Uh-huh.
But it can happen, for instance.
But that will increase the cost, right?
Yes, but that is for the patient's sake.
The patient may not need that. A second question is, what is the liability of the clinical laboratory? So if there is, especially when false negative happens, false positive probably is a little rare, right? Because you need to do the other confirmation.
Yeah. So I can tell you, of course, not the details, but there have been laboratories that I came to know what happened, that they did a prenatal testing, and the prenatal testing was showing a alteration on chromosome 15, and usually chromosome 15 can be associated with Prader-Willi and Angelman, and so these happen to prompt the mother to elect for termination. Then it turned out that this deletion was in the region of Prader-Willi and Angelman, but it was actually a polymorphic event. So this led to a lawsuit where...
But this is the false positive side. So it's the real practice needs to have another confirmation to if they really need...
They confirmed the event.
Okay.
This was a incorrect clinical interpretation of the event.
I see.
So
event is correct.
technically, everything was confirmed.
I see.
It's just that there was a polymorphic change.
Okay. So that's the false positive. How about false negatives?
Same thing is that that you can have pseudogenes There is one gene in particular. There are gazillions of examples. It's called ASS1. Don't ask me why they chose this name, but it's causing citrullinemia, which does not have anything to do with the acronym of the gene. And this gene has 14 pseudogenes that are known. So there have been cases where the variant was not detected because actually it was off target. But the variant could have been there, the two variants, because it's autosomal recessive. Or cases where the variant was detected, but was detected off target. So it's like PMS2, for instance, in cancer. So exons 12 to the end of the 3', they have practically, it's almost 100% homologous with the pseudogene. So you have to do a long-range PCR and sequencing in order to confirm everything that occurs in those exons in order to make it on target or off target. There are a lot of variants that happen off target, but they are not clinically relevant. And there are some variants that are on target, but they have not been detected because they just check the wild type from the off target. And these can lead to lawsuits.
Okay. Yeah.
And
I would assume so.
and the shutdown of the laboratory.
Yeah. Other questions? Yeah.
So it seems you, the panel you mentioned over here regarding the incidental findings, the 23 hereditary cancer syndromes, all of those, they don't have an age bar, right? Like you can report them even before like 18 years for Huntington syndrome, susceptible to it, because Huntington can be an incidental finding, but that can only be reported after if the patient is 18 and above.
Well, so there are two different issues here. So one is that Huntington is not recommended to be. No one is recommended to be tested for Huntington before 18 years of age. And there are social implications, emotional implications, ethical implications. And as you can see, the Huntington gene is not in the list. There are, on the other hand, this list is encompassing all those genes that may have an importance later on for instance, let's assume that, okay, you have exome sequencing of a 16 years old female Caucasian with intractable epilepsy. They have done a epilepsy panel, nothing, negative. So they go for whole genome. And then they identify another variant frame shift in BRCA1. So this is a female, 16 years old female, which will have a overall risk of developing breast cancer between 85 and 90% in her life. You must report it. It's ethically compelling to tell this patient that they may not die of epilepsy, but they may have breast cancer.
So the ACMG recommendation is basically saying these are the list of the genes. If you see it, you have to report.
You have to,
but not anything more. So if you see other variants, and you cannot report it.
The ACMG can, gather back and decide that they want to.
List
yeah, exactly. Those are the must reported. Everything else can be, discretionary depending on, for instance, if there is something else that a new gene that was, identified after the guidelines. So let's assume that they are there, but let's assume that for breast cancer, let's assume that the guidelines were done when only BRCA1 and 2 were discovered, and then there are CHEK2, PALB2, and so forth. then obviously you know that those genes are also associated with the same disease, although different risk percentage of risk. And so those are the conundrum where the clinical laboratory they are bound to report if it was on BRCA1 and 2. And I give you an example. This is not because all those genes are there, but just to give an example. But if it is a new gene that was not known before, but you know that the association and the risk has a certain percentage in the lifetime, you may also elect to disclose. You can ask also the ACMG, body, so the American College advice as whether these genes should be also reported as well. So it's not that you cannot do it, but you have to do it through proper channel.
Any other questions? Okay. Everything being covered here will be in the exam. Okay.